So as many of you know, healthcare and healthcare policy has been a passion and a profession of mine for over 20 years. And I do, as a part of that, want to, just from a full disclosure standpoint, let everyone know, and we'll hear more about this today, but I have been appointed by the administration to serve on a 17-member task force to make recommendations on issues related to a health insurance exchange framework for Minnesota. And Commerce Commissioner Mike Rothman, one of our panelists today, chairs that advisory task force. So I just wanted to be clear that everybody was aware of that. Our goal today really is to provide you with information and have a discussion around the healthcare reform. So not many people are as strange as I, and there's others in the room I could point out, who actually read the 3,000-page healthcare reform bill, or 1,700 pages. It really depends on which font you read it in. But nonetheless, it was long. And it's very complex, and I think we all know healthcare is very complex as well. And so what we really wanted to do today was to provide value to you, to provide you with some information, then have a discussion because, you know, not surprisingly, there's different views of this legislation, like anything large that happens in Congress. So to that end, we are very fortunate today to have with us an expert to give us a solid foundation on this subject. So I'm going to introduce Julie Saunier to you in a moment, who will share her wealth of knowledge on this with us. And then after Ms. Saunier concludes, we'll go ahead and invite our panelists up to have a discussion on this. So let me start by introducing Julie Saunier. Ms. Saunier is Deputy Director of the State Health Access Data Assistance Center, or SHADC, because that would be hard to have to say that every time, right? At the University of Minnesota. SHADC is an independent health policy research center that helps states collect and use data to inform health policy decision makers. Ms. Saunier has extensive expertise measuring trends in state healthcare markets, including trends in healthcare insurance and how health plan and healthcare provider markets are changing over time. Prior to joining SHADC in 2010, she served as director of the Health Economics Program at the Minnesota Department of Health. In this capacity, she was extensively involved in the development and implementation of state-level health reforms. A focus of her work is helping states to think about key measures that will be important for monitoring the impacts of federal health care reform that were enacted in 2010 and how to get the information that will be needed to help policymakers understand the law's impacts. She holds a master's degree in public affairs from Princeton University and has an undergraduate degree in economics from Amherst College. Please join me in a warm Twin West welcome to Julie Saunier. Thank you. In the next 15 minutes or so, I'm hoping to give you a little bit of background on sort of general healthcare trends and why healthcare reform is an issue that's at the top of many of our minds. Give you a little bit of a high-level overview of Minnesota and federal health reform laws that have been passed in the past few years, and then talk a little bit about their impacts on businesses. So in terms of setting the stage, healthcare spending has been growing rapidly in recent years, but it's not a new problem. So it's been, this trend line shows what's been going on with healthcare spending since 1960, when the federal government first began keeping track of these trends. And this is per person spending over time. And, there's both projected and actual there. So in 2010, we're spending about a little over $8,000 per person. By 2020, we're projected to be spending over $14,000 per person. So it's, a very rapid increase. Probably more significantly, though, is that it's a growing share of our economy. So as a percentage of the national economy, it's risen from about 5% in 1960 to about 17.5% today, and is projected to increase to around 20% in the next 10 years. So this is why this is taking up so much of our attention, so much of our, is considered such a large problem, because to the degree that healthcare spending grows more rapidly than everything else, particularly from an employer's perspective, an employer that provides health insurance benefits, it leaves less room for things like wage increases, investments in the business, those kinds of things. So that's why this is so much at the top of our minds.
A few other key facts. Minnesota has historically had among the nation's lowest rates of uninsurance, and it's very much the case that this is because of the high rates of employer-based health insurance that we've had in this state. In the past decade, though, the share of people who have employer-sponsored health insurance has fallen very significantly, both in Minnesota and elsewhere. So of working-age people or people under age 65, the share who have employer health insurance fell from about 80% 10 years ago. Now it's about 70%. So there's a very rapid shift. There's a lot of things that are going on there, and it's not just because of rising costs, but rising costs have certainly played a role in that. And when that happens, there's a couple of other things that take place. One is that we get rising enrollment in public insurance programs like Medicaid, which are supported with tax dollars, so that creates pressure on the state budget, pressure on taxes, and we also have a rising number of uninsured. The final sort of key background fact that I wanted to point out is that healthcare and health insurance together account for over 15% of private sector jobs in Minnesota. So, and these generally are good jobs, and we like these jobs. So it's not that in controlling healthcare costs we want to get rid of these jobs. I think really the key question is, can we get a more efficient system that covers more people at a sustainable cost? And we very much value the contributions that the healthcare sector makes to the economy. So it's not that it's not making a contribution. It's about how can we do this more effectively? Can we find a more sustainable way to move into the future? And then finally, cost and quality of care are uneven. And this is a key point that I won't really have time to do much justice to today, but if you want to think about controlling costs, what are the real drivers of cost, this is what we need to be thinking about. So we're having a lot of debate over who should be covered by what and who should pay for it and what are the mechanisms of coverage. But really, the key place where we also need to have a lot of focus is on what's driving cost trends. What is the value that we're getting out of the money that we're putting into the healthcare system today? So there's very wide variation in costs. Back in 2008, when we were working on the Healthcare Transformation Task Force under Governor Pawlenty, one of the statistics that we had was that there's a 60% difference between the high-cost and low-cost provider clinics that participate in the state employee group, and that's pretty much every clinic in the state. But that's not explained, and it's not associated with the quality of care that those clinics are providing. In fact, sometimes there's an inverse relationship. And there's very wide variations in quality across Minnesota provider groups. So just as a couple of examples, the percentage of diabetics who are getting optimal care for their condition ranges from 2% to 61%, depending on what clinic you go to. Percentage of 2-year-olds who are up to date on their immunizations ranges from 52 to 92%. These are opportunities, I would say, to where we could be looking to improve the value that we're getting for the dollars that we're spending on healthcare. So I mentioned a minute ago that there was a healthcare transformation task force that existed in Minnesota in 2008, and I helped to staff that task force and spent a lot of time, and there was a very significant representation from the business community and from healthcare insurers and providers on that task force. And a primary focus of that task force's work was to say, look, we've got to get costs under control. The only way to do that is by changing the way that we pay for care to get better incentives for getting the kinds of outcomes that we want and the kind of value that we get out of the system. So that did end up in a major piece of legislation in 2008. And the primary focus there was on transforming the delivery system to get better value at a sustainable cost. There are many, many other provisions in the law, and I don't want to give short shrift to the provisions that expanded public and private health insurance coverage and also on improving public health. But for purposes of this talk, I wanted to focus on the provisions that promote quality and value. In contrast, I would say the 2010 federal health reform law focuses primarily on insurance coverage. And so this is about who has what kind of coverage and who's paying for it. And that's not an entirely fair characterization of the law. It does do many, many other things, but a lot of the public debate about that law has been on these sort of coverage-focused kinds of questions. So key things key strategies that law is using to reduce the number of uninsured. One is expanding the eligibility of public coverage, and that's mainly Medicaid. Second, by increasing private insurance coverage through a variety of mechanisms. One is by providing subsidies for individuals to buy private coverage. Another is by providing tax credits for small employers to offer insurance coverage. And then a third is by putting in place some penalties for large employers that don't offer coverage. So all of these things combined are supposed to increase the rate of private insurance coverage. And then there's a number of provisions aimed at improving both the affordability and the comprehensiveness of that coverage, because it's not just that you have coverage, but once you have coverage, you need to be able to actually afford your co-payments and have a comprehensive set of benefits that protects you financially. The federal law also complements Minnesota's efforts in a number of ways. The Transformation Task Force in 2008 recognized that it's important to have a critical mass of payers for healthcare all on the same page and sending common signals to the market. So it's one health plan or one employer can decide, well, you know, I really want to do something to drive better value and contain cost in the system, but no health plan and no single employer is big enough to do this on their own. And so there was a very strong focus on getting common sets of information that people could use in their own ways to drive better value and contain costs in the system. So some examples in the federal law that are very complementary to some of the efforts that Minnesota is undertaking on its own are payments for healthcare coordination. Medicare is going to start making payments based on quality and value of care, and this thing called accountable care organizations, which in a nutshell is basically giving healthcare provider groups incentives to be accountable for the total cost of care rather than getting paid on a fee-for-service basis for every sort of single thing that you do. Because when you're getting paid by volume, the incentive is to produce more volume. So this is to sort of focus on the entirety of, taking care of a population of people and being responsible for the cost of care for that population. And then finally, developing better measures of cost and quality that people can use to do more value-based purchasing. So major provisions of that law that relate directly to employers, there are many, and I've summarized a few of them in this chart, and it varies depending on the employer's size. So for small employers, there are tax credits. For very small employers, you have to have 25 or fewer employees. Tax credits as an incentive to offer health insurance coverage. For larger employers, there are potential penalties in the future for those that don't offer coverage if their employees end up getting subsidized coverage through a health insurance exchange. For all employers, there's a requirement to provide if they provide health insurance that they offer dependent coverage, that they allow dependents to be enrolled up to age 26, and eventually lifetime and annual limits on benefits will be eliminated. So there's a few things in this chart that I've marked with a star, and those apply to employers. It's called, if employers have what's called a grandfathered plan, which means they really haven't made any substantive changes in their plan since the time that the federal law was enacted in March 2010, then these things would not apply to them, but otherwise they will. So it's guaranteed issue and renewal of policies, which means employers can't be turned down when they go to buy coverage. They can't be refused to renew their policy. There'll be first dollar coverage for preventive care, and then there's going to be something called an essential benefits package, which really has yet to be defined specifically by the federal government, but to be considered the sort of the minimum essential coverage to meet the requirement to offer coverage. There have to be certain sets of things that are covered at a certain level. There are two kinds of impacts on businesses that the health reform law will have, and the direct impacts get a lot of attention. So one is, what's going to happen to my health insurance premiums? Another is, well, what will employers do with regard to deciding whether to offer benefits at all? And so those direct impacts include things like, how will employers react to the incentives and penalties in the law? How will they take into consideration some of the alternatives that are going to be available to their employees under the law? And then there's also a set of impacts that are more indirect. So the cost and quality initiatives are much less direct, but I think much more important from an employer's perspective in the long run, because that's really what's going to determine whether costs are sustainable. Employees' decisions and behavior, and then sort of how does the law affect health plan and provider markets in terms of how competitive those markets are and their ability to keep costs down. So in this chart, I try to sort of separate out those impacts into things that are going to have an increased premiums, things that on balance are likely to decrease premiums, and things that are going to be kind of mixed in terms of affecting people differently. The lifetime and annual limits provisions, the preventive care, expanding dependent coverage, no pre-existing condition exclusions, and new taxes, on balance, those things would all tend to increase premiums. On the other hand, there are limits on health plans, overhead, and profit, which would, on balance, decrease premiums. You know, what I would say for both of these first two categories of things is these are things that, in some cases, to a very significant degree, have already been in place in Minnesota, and I don't think that they will have large impacts on premiums. They might sort of be a wash in the end, or maybe a small increase. The thing that I don't think too many people are paying attention to is this last one in the third column, which has the up and down arrow, which says there's going to be no pricing of health insurance premiums based on health status, except for tobacco use. So right now in Minnesota, in the small group insurance market, premiums can vary from the healthiest to the least healthy groups by as much. The healthiest groups can have the least healthy groups can have a premium of that's as much as 1.7 times the premium for the most healthy groups. That ability, you know, the rating is going to change, and healthy groups are going to have premium increases, and unhealthy groups are going to have premium decreases under that. In some cases, those may be substantial, and that's something I think is not getting very much attention right now, but will in a few years when those factors start to come into play. So one key question is, will employers continue to offer health insurance benefits? You know, there was a study that came out last June, and it got a lot of press coverage, so many of you may have heard about it, which said that 30% of employers were likely to drop health insurance coverage because of the new federal law. The study itself got a lot of press coverage. The retraction of the study that came a couple of weeks later didn't get very much coverage. You know, what I would say is there were a couple of very, very significant problems with this study. One was it was a survey of employers. Well, first of all, the study didn't really back up with any details, just said our proprietary research shows that 30% of employers are going to drop coverage. When pressed for details and the details started coming out, it turned out, well, it came from an employer survey. They were surveying employers, but the things they were asking employers, first of all, revealed that employers didn't have very much information about the health care reform law, and the people that were asking didn't know very much about their own company's health plans. And so I would not put a lot of stock in the results of that particular study, but it did get a lot of coverage. It is likely that some employers will drop coverage, and that's predominantly probably going to be the case with those that have a low-wage workforce, because those workers, many of them may become eligible for Medicaid or subsidized coverage in the exchange. You know, most employers, though, who offer coverage today, because low-wage workers right now low-wage employers right now are not very likely to offer coverage in the first place. So I'm not sure that there will be a very large impact of those employers dropping coverage. There's going to be some offsetting increase in employer-based coverage by more people taking up those offers because there's an individual mandate to have health insurance coverage. So the evidence from Massachusetts to date is that the percentage of employers offering health insurance coverage is up. Massachusetts is the only state where this has happened at all in the last several years. The Congressional Budget Office, which is the official scorekeeper for Congress, estimated that there would be some increases and some declines in employer-based coverage as a result of the law, but on balance, it would be roughly stable. So next question is, will employers participate in the health insurance exchanges? And specifically here, I'm talking about an option called the Small Business Health Options Program, or the SHOP exchange, which is different from, I think, a lot of the coverage that the general issue of health insurance exchanges is getting in the press. So these are very specific. So the general one is a place for individuals who don't have an offer of employer-based coverage to come and potentially qualify for subsidies to buy private coverage. This, on the other hand, is a place for small employers to go and purchase coverage for their employees. So the degree to which employers are going to want to take advantage of this option obviously depends on the value proposition that the exchange is going to be bringing to them. So, you know, what are the products that are going to be available there, at what price, and how easy is it to do business with the exchange? You know, a couple of things that I think are working in the exchange's favor is that it is possible that the exchanges can be set up in a way that supports a model where small employers can move to a defined contribution model for health insurance benefits. That's something that we know employers in this state have been interested in for many years. So that may be something that attract them to the SHOP exchange. And then again, the tax credits for small employers to offer coverage will only be available to those that purchase through the exchange for 2 years. You know, the evidence to date is there are 2 states that have small business exchanges up and running. Those are Massachusetts and Utah. And the Massachusetts exchange has been very successful in attracting individuals to buy coverage, much less so on the employer side. And the Utah exchange has also had difficulty attracting very significant numbers of employers. So a little bit of an uphill road there, but some promise, I think, depending on how it is structured. And then finally, with regard to cost containment, and as I mentioned before, this is an issue that employers should be very, very interested in, because this is really the key to the long-term sustainability issue. Employers can play a role by choosing benefit designs that provide individuals incentives for appropriate use of care, by supporting efforts to improve healthcare value through changing the way that we pay for care, and encouraging healthy lifestyles. All of those things, of course, are things that we don't need a law for employers to be able to do. But one of the things I think that both the Minnesota law and the federal law do is sort of bring some support to this idea that if all of the purchasers, because the federal government is a very large purchaser through Medicare, state government is buying a lot of health care through Medicaid and through its state employee programs, other public employee plans. If you can bring all of those groups together, at least have a common and consistent philosophy and approach, and using a common set of tools, a common set of information about, well, what is cost today, what's quality today, where do we want to move it in the future, then I think there's some opportunities there to significantly leverage improvements in those areas. So I think that employers should be paying attention to these new initiatives and opportunities, and take advantage of them and build on them where possible. I will stop there. My contact information is there in case anyone wants to have some follow-up questions, wants to contact me afterwards.
So I think, Julie, if you are available to stick around a little bit after, there might be a couple people have questions. But otherwise, I think now we're all clear. Is my honest, right? Everybody can go back to their office and explain to everybody else what it is. Actually, Julie did a very nice job. This is a very complex set of issues, and thank you very much for really just kind of giving everybody that level setting that I think is important for this discussion. So I'm going to go ahead now and introduce the panelists that we have for our program. So we first have Senator David Hann. Senator David Hann is currently serving his 3rd term as a state senator representing Eden Prairie and Minnetonka. He serves as the Assistant Majority Leader and is chair of the Senate Health and Human Services Committee. He also serves on the K through 12 and Finance Committees, as well as the Legislative Audit Commission. A Minneapolis native, he attended high school in Bloomington and college at Gustavus Adolphus in St. Peter. During his sophomore year at Gustavus, he chose to fulfill his duty by volunteering for service in the United States Army. He served 1 year in Vietnam and received the Army Commendation Medal. After graduating from Gustavus with a degree in religion, he pursued a degree in theology at the University of Chicago Divinity School. Prior to his service in the Senate, he was elected 3 times to the Eden Prairie School Board, where he served as clerk and treasurer. He was also senior manager at E.A. Sween Company, or Deli Express, for 22 years, where he served in several capacities, including Director of Forecasting and Logistics. He and his wife, Ann, have 4 children and 1 grandchild. So thank you very much, Senator, for being with us this morning. We also have with us Commissioner Mike Rothman. On January 12th of 2011, Governor Mark Dayton appointed Mike Rothman to serve as Commissioner of the Minnesota Department of Commerce. Commissioner Rothman brings a distinguished record of consumer protection to the Department of Commerce and extensive public and private sector experience on insurance and financial service-related issues. Recently, Governor Dayton called on Commissioner Rothman to lead the Insurance Exchange Task Force, tackling the design and operation questions for the insurance exchange. A graduate of the University of Minnesota Law School, Commissioner Rothman began his career as a law clerk for the State Court of Appeals in the late 80s and early 90s. He worked for the state Senate, leading efforts to reform the state's regulatory laws. He has litigation experience. That experience began when he worked on the insurance insolvencies of Mission Insurance Companies and Executive Life, two of the largest in U.S. history. He was most recently an attorney with the firm of Winthrop and Weinstein, where he was co-chair of the Insurance and Financial Services Practice Group. And he and his wife and their 3 children live in Minnetonka, where I believe you are a constituent of Senator Hann.
Yep, that's
Okay, so
It's a
that could
little
just
known-
bring an interesting spin here. Okay, so thank you both for being with us this morning. Thank you. I feel like I'm really far behind you, so don't feel the need to
Oh, it's
turn and
okay.
look at me. when I-
Are these on?
I think we're on. And they do have a tendency, you typically have to bring them quite close for them to work well. So let's just start. I think the question I'd like to start with is, Julie outlined that there are elements of healthcare reform that are aimed at assisting employers, particularly small employers, to help them pay for health insurance. There's also a lot of elements of this legislation that will introduce new challenges to employers and new considerations for employers. So let me just kind of toss this up in a general question of overall, do you think this legislation is a net gain or a net loss for employers? So Commissioner Rothman, do you want to start with that?
Sure. I believe that it's a net gain. There's a lot of reasons for that. Julie touched on a couple of them. But when you look at what the overall goal of the Affordable Care Act is, it's really to try to get at the cost of health care. Let me start by saying, when you look at the statistics, Julie gave some good ones about the GDP, but when you focus on the impact on small businesses, think about this, 150 million folks get their health insurance through the employer-based system. The average annual cost for family coverage is $15,000. Employers are paying $11,000 of that coverage right now, and for individuals, they're paying about $4,000. So the impact to businesses is significant. And I think several parts of the Affordable Care Act are important. One is the small business tax credit. I think 67% of Minnesota employers they employ people employees of 10 or less. And so it's a very important thing for all small businesses to look at that as an opportunity. The second is what is the exchange, and we'll talk a little bit more about that in detail. And I think another significant point that Julie pointed out under the exchange system would be is a shift to a contribution system rather than a defined benefit plan system. There are some challenges, there's some uncertainties. I know we're going to talk about those, but I think with more information, businesses will have a better opportunity to make some choices. The governor has launched not only a health reform task force, but also the exchange task force, which I'm chairing. We just put up a website that will be good for small businesses to take a look at. It's up live. It went up yesterday. We are also tweaking it, and it'll have it actually has a lot of information from small businesses to get that information. But I think as we go along, the more information small businesses have, the more clear it will be, and the better opportunities we'll have for all of us.
Thank you. Senator Hann, how do you think this will play out for employers?
Well, I think that I may differ a little bit in my perspective from the commissioner. I think there may be, in the short term, for some employers, some gain or some reduction in their costs as a business. If the law, as it's written today, goes into effect without change, that may be true. But if you're asking on balance, a net result over some period of time, I think that it is unquestionably true that this system itself will be much more costly, and ultimately the costs for that will be borne by taxpayers, and that means a lot of businesses will see taxes that will have to go up to support the kind of things that this law requires them to do. So I think that you may see initially, as some of these things come into play, that employers will find an opportunity to handle health care costs for their employees in a different way that may shift some of that cost burden into some other structure, a governmental structure perhaps, or there may be credits or or other things that may be beneficial, but over time, the overall cost of the system is going to far outstrip, I believe, the short-term benefits that people may see. The reason I'm skeptical about this, and I think if you go back, and I've been looking at this, and I don't claim to be an expert. I'm relatively new to being a chairman of the Finance Committee in the Health area in the Senate, but I've done a fair amount of reading about this. If you go back and look at the changes in the way our health care has been provided in this country over a number of years, and there's been a lot of changes, going back to about 1960, which is, I think, the starting point in one of the graphs that Julie brought out. In addition to the change in costs that she's pointed out, you also have to remember that in 1960, about 75% of all health care costs were being paid in the private market. And about half of those costs, half health care costs, were being borne by individuals, and much of it was out of pocket. Today, you've got over half or almost half of the costs of health care being borne by government, and about 10% that is being borne by individuals. You see a huge shift. And what has been the cause of that shift? I think it's unquestionably true that the introduction and the implementation of Medicare and Medicaid in the 60s, mid-60s, has contributed to a very large degree to the inflationary pressures and the inability to manage costs because of the interference in the marketplace by a third party, namely mostly government, and causing it to be very difficult for ordinary users of health care and health insurance and providers to get clear signals about what the market wants and how to provide it. So I think if you look at those things and say, how have we done in the past with containing cost over the years with government mandated and government implemented programs, it hasn't been good. And when we look at this law that most of us do not understand completely in its complexity, there are many things about it that have not even been fully explained. And so there's a lot of uncertainty about this. I think the uncertainty itself for a period of time is going to be problematic and may cause pressures on costs as well. So I am not a believer that this is a model that will work, and I think that we ought to be very cautious about what we do so that as we go forward and begin to see the results of these things that we can undo them, which I think we will need to do.
I would just like to add as well. So, I'm throwing these questions out. If either one of you want to react to what you heard the other person say, please feel free to go ahead, and I'll just ask questions when it's quiet. So, so let's, one of the things, and Julie did a nice job of kind of touching on this, when we think about healthcare, we really think of kind of this triple aim, which is, the cost, the quality, and access. And all of those are incredibly important, and they really have to work together. And I think, as Julie alluded to, this legislation, while it contains elements of all three, it really focused on the access piece, which is incredibly important, of course. But there are some who say it really didn't do enough on cost and quality. So how would you react to those folks who say it didn't do enough on cost and quality, and what do you think it could have done? What do you think are the missing elements, if you do think that is true? So, Commissioner?
I believe that when we all look at the facts, that there's a lot of truth in everything that we're saying. The Affordable Care Act does have some limitations. It tackles some very, very major issues. At the same time, you've identified a couple of them that Minnesota has been well ahead of the curve, well ahead of the United States in very important ways. Julie mentioned the original task force. That task force focused on quality and value, and how do we get costs under control. Without those costs under control, as Senator Hann pointed out, those costs are the base of the system, and you can see those projections going up. So we need to tackle those questions. And in Minnesota, we have to do it in a Minnesota-made way, in a Minnesota with our unique system. We have one of the best healthcare systems in the world here in Minnesota. We get health care. We also understand that we have to focus on those costs, and we need to turn to quality and delivering value, not just delivering services. And those are the key questions. And I think that we need to continue in Minnesota to work on those things. And here's at least from our perspective, and we have to do it collaboratively. I think all of us understand that. We, administration, have reached out and are working with small businesses, the Minnesota Chamber of Commerce, the Minnesota Business Partnership, the health plans, the brokers. We're trying to develop a base foundation to understand what are these key value proposition needs that we need to do for Minnesota. With respect to the issue of government and how Medicaid is, how it delivers services, I just wanted to make at least one comment that the administration took a quick look at a lot of these things right from day one in January. With respect to the cost, the administration shifted to a competitive bidding process for its plan with the public program system, so that it's now focused on whoever can deliver the best value and the best price for the services that we have in Minnesota. The second part of this is that when we look at what we're dealing with the insurance exchange, we are focused on not just what the federal government will do. In fact, if we don't do something in Minnesota for an exchange by January 1, 2013, the federal government will slap a one-size-fits-all exchange on Minnesota. And I think it's very important for all of us to work collaboratively together to think about what it is we want a Minnesota-made exchange to look like. Julie mentioned both Massachusetts and Utah. They each have their advantages, but they also have disadvantages. And we need to use the best practices. We have to harness what's best from them, but probably combine them, both an individual marketplace, a small business marketplace, and have a market-driven exchange for Minnesota so that we can offer individual coverage, small business coverage through the exchange, and have a fluid marketplace where there will be increased portability. There will be focus on, we can build into the system a way where we have network adequacy, network value choices right there for you as business owners to help you get the insurance coverage you need for your employer. So there's a lot that can be done. There were limitations, but I think we have to focus on what's good for Minnesota and to do it in a collaborative fashion, using the common sense of all of us.
Well, and I do agree that the question about who decides policies with respect to healthcare and who makes decisions about healthcare provision and cost and what works for people, that question is very important. And I'm glad to hear that there are people who agree, as I do, that the decision making ought to be in Minnesota. And I think this is one of the fundamental problems with the federal law. As I understand it, and I confess I don't have complete understanding, though I don't know anybody who does, but everything that I have seen about this law does nothing except make it more difficult for Minnesota to make decisions about health care in Minnesota. That is a real fundamental reality of what federal law does. We have a lot of federal laws today that govern the Medicaid program, and our state budget in health and human services, we spend about $11 billion in state money. There's an additional $9 or $10 billion of federal dollars that comes in. All those dollars have conditions and strings and mandates, and in the course of dealing with our budget in the last session and trying to find ways to do things differently. And there are people on both sides of the political aisle trying to do this, and every time you'd think you had something that might work, well, you'll have to get a waiver from the federal government to do that. And so I think it's true that Minnesota has done a better job than many states at providing a health care structure in Minnesota that is working better than other states for a variety of reasons. But to then, on the other hand, say that the best way to improve that is turn over the control and the decision-making about healthcare to the federal government seems counterintuitive. Now, I understand that one of the things that is being talked about, and the Commissioner mentioned the exchange, and there is, I think, some value in the marketplace for exchange. I've looked at the Utah model probably a little bit more than the Massachusetts model, and I think there are some virtues to that model that would be helpful. However, the Utah model doesn't conform to the federal law. And this is the problem. If you design a structure that is going to solve problems in Minnesota that makes sense to businesses, insurers, and consumers in Minnesota, it will probably not conform to what the federal law wants you to do. So then what are we going to do? We have the choice then of saying, all right, we could do that, and then just sort of say to the federal government, make us, which they may, or they may come in and throw the whole thing out and say, here's the thing you're going to have instead. Or we just say, well, let the federal government do it because ultimately they're going to get what they want anyway. The rules, as I understand about exchanges from the federal government, give states some flexibility, but not enough, I don't believe, to make a significant difference from state to state about what actually gets done. And this is a big problem. We talk about quality, cost. Those are important questions. But again, the question is who ought to decide those things? When we look at quality typically at the state government level, what we're doing is we're saying, let's get some people in a room. It might be a task force. It might be a committee in the legislature. We bring people in. We hear testimony. We hear ideas. And we start writing down things, and they become rules, and they become laws. And we say, well, we're going to set some standards about what good quality is. And then we start to implement those, and then we put rules and we force people, compel people to abide by those things, so we provide strong incentives to do it in the way that we distribute money. And so we begin to define what that is. What does it mean to have a quality thing or a quality service? All those things, I think, add cost, and they may not at all conform to what individuals believe are quality. If you look around most of what we do in the economic arena, there are not state rules about what is a high-quality computer, or what is a high-quality retailer, or what is high-quality clothing. All these things are decided in the marketplace, and it's because individuals have different things that are of importance to them that go into that quality value calculation. When I worked in the private sector for a food manufacturing company, that's a very important question, recognizing that not everybody is going to respond in the same way. And the challenge is to find products that are going to give people choices and options so that they can satisfy their own quality expectations and their own price expectations. But when you have a committee who's going to do this for everybody and say, this is what quality is and this is what cost should be, you've done great harm to the ability for the marketplace to judge and to find variations that are critical if you want to find ways to hold down costs and innovation. So I think the question of who decides is very important. I would argue that the first decision we ought to make on that question is not have the federal government decide, but have people and policymakers elected in Minnesota make that decision. And then our job as policymakers is to do everything we can to make sure that as much as we can, that the decisions about choices and products are in the hands of individuals. That's what we should be working for. And I don't believe the federal law does anything to move us in that direction.
So one of the areas with, I think there is a lot uncertainty about this. And so just, looking out to the audience of, business owners and working for organizations, how many feel of you that you don't know enough about this legislation to make a decision on how this would impact your business or decisions you make for your employees? Did I ask that as a double negative? How many feel they don't understand this very well? So, well, great. A lot of people seem to really understand it. So we'll come and teach us. But, and I think that there is a lot that is really that uncertainty, though, for businesses. And we hear this all the time. And it's not just about the healthcare reform legislation, it's in general. Businesses, we hear how much cash is out there in corporations right now and businesses, and they're holding on to it. And I think what businesses would say is we're holding on to it because we don't know what's coming at us. And so I think healthcare is another area where that uncertainty. And I think what I'd like your perspectives on, I know you both have been out talking to the community about this, that, I've even heard, and this to me is really scary, But I've even heard people say, you know, if I have 50 employees, I have to start paying a penalty of $2,000 per every employee if I don't offer coverage. And it's very complicated, and Julie would be happy to explain to you how it all works. But you know, I've heard people say that speculation that they think companies don't want to grow past 50 employees because all of a sudden all these things apply to them. Now that's a really scary thought from trying to build the economy. So do you think that's just speculation, scare tactics, people don't understand it, or do you think that's a legitimate concern that could happen, Commissioner?
Well, as Commissioner of Minnesota for Commerce, I touch on the economy in many different ways. I regulate 20-plus industries, so it's insurance, banking, securities, energy, telecommunications, real estate, and I'm out I speak at least 2-3 times a week, and it's important for me to come out to groups and to be invited to talk to people like today. The number one priority for the administration is to make sure that as we continue to recover out of the recession, that we're focused on what it takes to grow businesses and to grow the economy in Minnesota. With that as a priority, the questions then become, with respect to health insurance, these are big, important topics. And then when you think about, you know, the specific question that you asked and the uncertainty, we all know that economic decisions are best made when you have as much information as possible. It's the way the United States works. It's the way the economic engine works. So the more information people have about the specifics, the better. As to this assessment, it's called the assessment in the ACA, there are some questions and uncertainties, but the federal government is looking at simplifying that right now. And I think if there's pros and cons to it, we have to focus on what it is. One of the first things we did in the administration at the beginning was to apply for some planning grant funds from the ACA so that we could look at this very question. So we we retained some very smart experts in economic modeling for health matters. And this is one of the questions we're looking at. And the initial information is that, you know, there may be businesses that drop, but there are also going to be some that pick up coverage, and it'll depend on each specific company's decision and then aggregating the decisions based on what happens as it gets implemented. And Julie pointed out a few things about that. I don't want to go over them, but I think it's too soon to tell, and we'd be speculating. And I do think for that reason we should just wait and see how it plays itself out. But I do want to say this, for those that want more information, our website on health reform has specific information about the assessment, who it applies to, links to the IRS with very detailed information about how it will go into effect, and I encourage you to take a look at that.
Well, I think that there's truth in the statement that we don't know for sure, because we are trying to predict the future. I did forecasting when I worked for Delhi Express, and the one thing that I tried to persuade my colleagues is that every forecast is wrong, and it's just a question of how wrong it's going to be. So you're in a business where you're telling people faulty information. That's what a forecast is. So to forecast the future of what's going to happen, I think is very, very difficult. However, I think it is, in my judgment, pretty clear that one of the contributing factors to the overall softness of the economy and the failure to see economic growth take off has been the uncertainty around the whole healthcare law. This is a huge piece of legislation. It covers a huge part of the economy. It affects every citizen in the country. Everybody has great questions and uncertainty about it. I think this question that is being asked here about the size of a company, and if you grow to a certain size, you're subject to larger penalties. I have talked to and know personally people who have small businesses who are very conscious of that and who are telling me that they are not planning to add more than 50 employees until they know what the effect of this is going to be. Now, I don't know on balance how many that's going to be, or there may be other larger companies that are, don't care about that so much. I don't know, but I do know that a lot of economic growth is centered on small businesses, small groups of people. And if you put a limit of uncertainty on growth on the small business sector because of the uncertainty and unknown things about this law, that has got to be a factor in what is happening in our economy. And so I believe that if we did not have this law at all, we would see a stronger economy today if for no other reason, is that a lot of the uncertainty about health care costs wouldn't be there. We already have a difficult environment with health care. We've had for a number of years. We all know that. We've tried to work on it. But when you've got something out here that is federal mandated stuff, nobody really knows what it's all about, how it's going to affect you. We just know it's coming down the road and it's going to hit us in a year or a year and a half out. And everybody's sitting back and saying, well, I guess I'll wait and see, which is what the commissioner said. We have to wait and see. And people are waiting and seeing. And I think until that becomes more certain, the desire to invest, to grow, and to take risks is going to be very limited. So I think this is another reason why we ought to question this approach to solving healthcare issues.
So let's talk a little bit about the exchange. Julie talked about please, Commissioner, please.
I think that we have a lot of places where we have common agreement, and our differences are few. We all know that the economic downturn started with the meltdown of the banking sector, and as well we have some turmoil in the international markets. The strength of the economy in the United States seems to have some stability to it, and we have some protection. I don't want to sound any alarm bells. What we want to do and make sure is this, and we all know this, that fundamentally health care costs, the trend in the United States is been going up, and it's trended up, and it's doubled, and it will continue to do so until we get our hands around the cost of health care. I think that is the fundamental issue that we all need to be looking at, regardless of which way we go in terms of health care reform. And to look at it in Minnesota and then say to ourselves, okay, well, what are the best things for Minnesotans, and how can we get our arms around the questions, access, affordability, and value? And without doing that and working together on it, I think we're just missing a huge opportunity to make our lives in Minnesota better. And I think we're all on the same page. We just have to figure out how to get there.
So,
can I comment on that point? Mm-hmm. And I agree with the commissioner that we all do agree on some general things. We do agree that health care costs have been going up for a number of years in this country, and that is a concern to everyone. The question that I am raising, though, is how do we address that and what caused that growth in the first place? If you look at the rate of inflation generally, and then you look at the rate of medical inflation, there's no question that medical inflation has far outstripped everything else. Why is that? And I would point to, again, the thing I said earlier. It has been almost singularly the one sector of the economy in which we have seen large and growing attempts to get our hands around it at the federal government level and also, in some degree, state government level. And so we have not taken the approach that says we can trust ordinary people and businesses to make good decisions, that they can figure out how to make this, how to provide the kind of information, that they can find products that are acceptable. We haven't trusted that. And we've tried to manage it. We have tried to take the path that many other countries in human history have tried to do, which is to get together a bunch of smart people and figure out a structure. I wish I would have brought in my picture of the new healthcare system as people have understood it. It's a big chart about this big, and it's got 1,000 lines and circles, and nobody can figure it out. But that is the nature of central planning, and that's what this is. It's an exercise in saying we can figure this all out, pass laws, and force people and force businesses to comply, and that will drive down costs, and that will improve quality when it has never happened in any other thing that we do. And the things that we are most proud of in this country that I think have been great successes, things like the way that we deliver and distribute food products, which is an industry that I was a part of. We don't have the attempt to try to manage this from the federal government level and tell what prices ought to be and what quality ought to be, and to start mandating people by this kind of, we're getting there, unfortunately, but we haven't had largely that kind of effort. And we have got the most robust, the safest, the lowest cost food manufacturing distribution system in the world and in human history. Why don't we use that as a model and say, let's turn this problem of health care over to a marketplace and work on restoring a robust marketplace to help people make decisions and give them assistance where they need to if they need financial assistance. But let's not try to figure it out on paper and then implement it through law.
So we just have a couple minutes left, and I do want to get to the concept of the exchange. And so I think the exchange, I think Julie did a nice job of kind of showing that, but think of the exchange as kind of a marketplace. Think of it like a Travelocity or an Expedia.com, where individuals who don't have access to employer coverage and employers up to 50 and potentially up to 100 in the beginning can go and shop for coverage. And the idea is that there's transparency to compare plans and to take a look at that for consumers. There's some things in the individual market already out there, like e-health insurance. So there are some comparisons too. So the question on this is, there was a lot of talk last session about whether or not the state should go ahead and pass legislation to explicitly say, yes, let's build an exchange. That didn't occur. We had the administration, Governor Dayton, as you referenced, Commissioner, went after some federal planning grant money to kind of start that. We have the federal exchange, or the State Exchange Advisory Task Force work that's going on. So talk a little bit from your perspectives of the pros of the cons of the state doing something, the state waiting to do something, just if you could kind of speak to that. So I don't know who wants to start with that.
I'm happy to
Okay.
go. Well, first of all, you have to start with the overall context, which is that if the state of Minnesota were given an opportunity to build a Minnesota-made exchange by January 1, 2013, if we don't have a Minnesota-made exchange where we work collaboratively to build one for Minnesota, then the federal government will, for states that don't, they're developing one that'll be a one-size-fits-all for all of those states. So we have very little time. We only have maybe 15 months left. There's a lot of work to do. It's a complex process that needs to be simplified. But think of it again as Travelocity, where you can pull up on a website all of the various plans for individuals and businesses, and you'll be able to shop, which is the senator's point, giving the information to individuals to make choices. It's a marketplace for people, for businesses to shop for insurance. You'll be able to look at the coverage plans, the pricing. If we do this right, we'll be able to give you access to the quality and value of the provider networks, so that you'll be able to say and look at which ones you want in terms of value, and you'll be able to look at this through a simplified exchange arena. I think that what we need to do is combine and figure out a common place where we can combine both individual coverage and business coverage. And the Minnesota Business Partnership, the Minnesota Chamber of Commerce are supportive and interested in making sure that Minnesota chooses a Minnesota-made exchange. And we put together this task force, and the task force has stakeholders from all interested parties. It's consumers, it's businesses, it's the plans, it's the brokers. And I truly believe that without all of us putting our heads together to figure out what is best for Minnesota, that we won't get this right. We need to make sure that it works for businesses. We need to make sure it works for individuals. The advantages of an exchange also include the fact that there'll be portability. You'll be able to move in and out of the exchange. There will be a contribution system that we can put into place. And I think we just need to take that opportunity to do it and work collaboratively for a solution for Minnesota.
So Senator Hann, we're going to let you have the last word here, looking at the
Well,
clock.
just briefly, I think certainly we all know about travel velocity, and there are other things of similar nature. I don't recall any federal law requiring that be created and managed by the federal or state government. That was a market-based solution to a market problem, and I think it has worked, and it has worked well. And to the extent that an insurance exchange of information can be created and operated similarly, I don't think anybody would have concern for it. But that's not what this is about. I think that what we're talking about here is a federal law that is very prescriptive. It offers some, it says, flexibility to states, but it's very unclear to me if you really have a lot of flexibility. If we look at past practice with federal law with respect to health care, they always talk about flexibility. When it comes down to cases, it's not there, unless you seek waivers, unless you go through a very convoluted process trying to get permission. So I think, and I believe that there are some things that need to be resolved in the marketplace that some kind of an exchange function could be helpful for. For example, I learned recently that Minnesota has one of the largest, maybe the largest population of people who have more than one part-time job. And those jobs in of themselves, as Julie pointed out, may not provide enough resources to provide a health care plan, but it's possible you could have the 2 or 3 employers who are hiring one person through some mechanism offer some money that could be pooled, and then the employee who's working for 2 or 3 different companies could take those various contributions and go to work. That's a problem that could be solved. There also may be some things dealing with how risk is managed that may require a state government to come in and say, oh, I'm going to be in the room while you guys talk about you insurance guys talk about how to manage risk so we can make sure that the public isn't going to be defrauded. I mean, there are things about this market problem that could be addressed in some form of exchange. But the thing that I'm troubled with is that the focus is on how do we conform with the federal law that apparently we don't really like because we're afraid they're going to do it to us if we don't do something else, which I think is almost a false distinction. What we ought to focus on is what are the things that we can do in Minnesota to solve problems that we can identify, and do that. And let's do that. And if it happens to conform with what the federal government wants us to do, great. If it doesn't, then I would say to the federal government, make us do it your way when we've got something we like. Why wouldn't we do that? I think that as a political challenge, I think the federal government would be very hard-pressed to go to 10, 15, 20, 30, and there are other states facing, obviously all the states are facing this, but many are doing what I've suggested of saying, we're going to solve a problem that works for us, and we're going to put that up, and it's going to solve problems we've identified, and if the federal government comes along and says, no good, well, we'll deal with that then. That is the perspective I think we ought to take on this problem.
You know, I want to thank both of you very much for being here with us today. We are very fortunate to have 2 very thoughtful leaders on this very complex issue. So thank you for joining us this morning. Thank you very much. And I also want to remind you, Terry, where are you going? You got to fill out your form. Have you filled out your form? Okay, so don't forget. Sorry. If you could have everybody mark an X now that you're fully informed on healthcare, do that. And then also our December 9th legislative breakfast program will be on the judicial selection reform. Our guest speakers will be Representative Mike Beard and Senator Julianne Ortman. So please do not miss that. Again, thank you very much to our sponsors, Grand Casino Mille Lacs and Hinkley, Comcast, Centerpoint Energy, Homestead Senior Care, and Swing Audiovisual. Have a fabulous day and a great weekend, everyone.